This is Chris Frank presenting an NGIG podcast on medication decisions in the frail elderly, subtitled The Forest for the Trees, and you'll see why we have that subtitle a little bit later. Thanks very much for this opportunity to speak to you. I think it's a very important topic. Part of the pleasure of caring for seniors is managing medications, because the decisions that are necessary to optimally manage medications are challenging, involve lots of other input, and usually involve some great complicated discussions with patients. As you see here, this is Madame Calment, who lived to be, I think, 122 before she subsequently died. I'd really love to see what her medication list was like. I suspect that it was probably fairly minimal, and maybe the best thing she might have done is to avoid seeing a physician. So what we're going to talk at today is obviously focusing on the medication list in care of the elderly. Recognize situations where it's a really important time to look at the best medication list, as in not just the medication list that is readily available to you, but the one that most accurately reflects what the patient's actually taking, to develop an approach to reviewing the medication list. And I think that recognizing situations in frail older people that should precipitate a review of what the actual goals of treatment are is really relevant. So kind of goals of care as it relates to medications is something that comes up a lot in palliative patients in general, but certainly should come up more often in frail elderly. So I have no sort of financial benefit potentially arising from this talk, and I certainly will work for hundreds of thousands of dollars. So I thought I would start off kind of unusually for a medical lecture with a quotation from Ivan Turgenev, who is a no longer frequently read Russian novelist from the 19th century. And he defines nihilism in a way that's maybe a bit more positive than the way we have traditionally viewed the term nihilism. So Turgenev states that a nihilist is a man/person who does not bow to any authorities, who does not take any principle on trust, no matter with what respect that principle is surrounded. The reason I put this in is that people use the term therapeutic nihilist, and I think it is generally viewed kind of as a negative term. However, maybe when we're applying therapeutics to the frail elderly, we should really consider it as being a positive as opposed to a negative attribute. So I want you to think about some of the types of daily dilemmas that you either have seen as a clinical clerk, or that you are expecting to see when you're out there on the wards or in clinics. I've got a couple of examples here. This one is somebody that I've seen, not obviously a guy with a body like that at that age, but an 86-year-old man who comes back from Florida and asked to be put on Crestor like everyone I met in Florida. And the real guy had sat around night after night with people around a campfire deciding or hearing what medications they were taking, and thought he was somehow being left out. The nursing supervisor asks you why you did not start an 88-year-old new resident of the long-term care facility on a bisphosphonate. You're uncomfortable as the attending physician starting 96-year-old on warfarin for AFib, as your family medicine resident is urging you to do. This talk was obviously designed for attending physicians, but think of this when you're trying to convince your attending physician what might be the balancing factors in their mind. A final one, a 92-year-old man in a nursing home who's got severe end-stage heart failure with an EF of 15%, significant symptoms and distress due to dyspnea, and he states that he wants comfort measures only. What do you do with his digoxin? What do you do with his Lasix, the Ramipril, the spironolactone? So I think an important concept in decision-making in frailer older people is deciding, is this patient frail? So part of our discussion about frailty really reflects what is this person's prognosis, and how does that impact on their likelihood of getting benefit from that individual medication in question. And what we see in this picture is the famous 100-year-old marathon runner contrasted with a gentleman whose marathon is probably just getting to the dining room each day. I once again haven't seen Mr. Singh's medication list, but suspect that two things are true. One, that he's not on a lot of medications to deal with multiple comorbidities, but also that he's probably healthier because he's not on a lot of medications. So how do you define frailty? the classic description is it's like pornography. You can't define it, but you know it when you see it. And we all know what frail people look like, even if we're challenged to describe the physiology of it physiology and social aspects of it completely accurately. So how does frailty develop? We recognize the patient in front of us with it as a combination of aging, the impact of chronic diseases with superimposed acute illness episodes, and usually a degree of social vulnerability. So this will impact function and particularly impact homeostatic reserve, meaning that people are more likely to have adverse reactions to medications. So how do we define palliative care, which is quite common or quite important as we're trying to delineate how do we estimate prognosis and benefit from medications? So my late mother had a fridge magnet that said, "Life is a sexually transmitted disease that is always fatal." And I think this somewhat black humor is good to remember for all of us. Is age a palliative condition? And does going to long-term care mean that you're palliative? The life expectancy of people going to long-term care is in the months as opposed to many years realm. However, it clearly needs to be individualized, as I've seen people take a therapeutic nihilist approach, maybe just because the person's going to long-term care, as opposed to because that individual needs to have a palliative approach taken. So it is worth thinking of the statistics of prognosis, because clearly the best people to do this are actuarials and insurance companies. So, dear Mr. Bin Laden, we regret to inform you we've abruptly cancelled your life insurance policy. How do actuarial tables actually look? And it's a startling figure that 25% of 75-year-old women will live for 17 more years. 50% will live for at least 11.9 years. So from where you sit, 75 seems pretty ancient. From where I sit, it's not so ancient. However, 50% of 75-year-olds will live to be in their latter part of their 80s. For men, it's not quite so good, but 25% of 75-year-old men will still live for another almost 15 years. So rather than relying on age, we clearly need to be relying on who is the person sitting in front of us and what will get them in the end. So I think some of you have seen this before, but this is the Living to 100 Life Calculator, and it's quite interesting to do yourself and to consider some of these parameters in your patients. So what are some of the sequelae of medications? I think the medications are usually described as being the classic atypical presentation, meaning that medications will cause things like dementia / cognitive impairment. Clearly medications will cause delirium. Medications will contribute to issues like fatigue, resulting in decreased function. Many medications are associated with fall risk. Medications are significant factors in sort of day-to-day issues like urinary retention, constipation. The list goes on, and I think if you think of all of those geriatric giants, most of them can have medications contributing to them. Ken Rockwood from Dalhousie teaches his residents that if the older patient is functionally declining, think of drugs, drugs, drugs before you think of anything else. And by drugs, 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 he means prescribed medications, over-the-counter, and then natural health products. So my own rule of thumb is that if you have a patient who's having trouble and functionally declining, or having any new onset of symptoms that would fit under the geriatric giants category, going to the medication list is a crucial first step. Particularly true in hospitalized patients where the functional decline is often much more apparent to you, but also as an outpatient, you have no idea what that patient's actually taking, so you have to think of medications and think of getting that accurate list that I alluded to. I think one other interesting scenario is when the patient is admitted to hospital and they start to get delirious, or they start to get postural hypotension, they start to fall, feel lousy, feel fatigued, be drowsy. It may mean that they were taking their medications for the first time as they were non-adherent before home. And I've had this recently with renal failure caused in 2 patients because they swore up and down that they were taking their diuretics, and only after we'd stressed the kidneys by actually giving them their diuretics did it come to light that they had been far less adherent than they had described. So I think it's worth thinking in medication realms that there's errors of omission and errors of commission, and you can read about this in How Doctors Think. I tend to do the errors of omission, which means maybe to do less to old people than I should, in quotation marks. I see in acute care often younger doctors doing errors of commission, where doing too many things to frail older people can actually have a negative impact. So it may be worth early in your career figuring out where you sit on this, and sort of try to ensure that you're not heading towards either of these patterns of error too strongly. So can clinical practice guidelines help? Clinical practice guidelines are obviously crucial. It should be noted that there has been at least one study looking at the application of clinical practice guidelines using vignettes that has shown that the average clinical practice guideline does not fully apply to frail older people, and in one study the application of guidelines resulted in an addition of 14 more medications to the patient's list. So clinical practice guidelines are just that, they're guidance, but you cannot apply them to an older patient without looking at the specifics of that person. What are some of the models of intervention for reviewing medications? First of all, the big step, as I mentioned, is thinking of medications and being willing to go, I think I better go look at this med list. There are a number of things to help guide your choices in medications. Probably the best known one is the Beers list. And most medical students know about this, and many, many family physicians do not. Mark Beer was a physician in the States who developed this sort of Delphi consensus explicit criteria for medications that older people should avoid. Including things like long-acting benzodiazepines, specific doses of medications, old, outdated medications such as some of the older oral diabetic agents. It's been fairly roundly criticized for being difficult to keep up with it, for using medications that are so outdated very few people would use them, and obviously in other parts of the world it's not very helpful from the point of view of medications that are available in those countries. The alternative is the stop and the start, which has come out of Ireland. The stop is kind of a listing of medications under different categories that you should consider reviewing in your older patient, and we'll provide you a link for that shortly. And the start is that less common thing of, are there medications that are not on this patient's list that you should consider? So I think the stop and the start, particularly as a junior person when you're trying to kind of get comfortable with medications, which is one of the big challenges of medical training, the stop and the start may be a good thing to have at your fingertips or on your smartphone as a way of going, for this individual, what would be reasonable things for me to look at critically, and what would be reasonable things for me to consider adding? This other term, deprescribing, is one that I've gained interest in, and I must confess that preparing this talk for a group of family physicians really made me look at a little bit more critically at how aggressive I was at stopping medications as opposed to trying to optimize the medication list. And deprescribing seems to be something that has been identified as or has been really publicized mostly in Australia, in that any article I find from it is done in Australia. There are a couple of hospitals in Canada that are starting deprescribing programs, but we'll spend a little bit of time looking at some of the challenges of deprescribing, and obviously my own perspective is I'm trying to deprescribe in frail elderly as opposed to just optimizing the list. The two are similar, but hopefully deprescribing means that people will be off more medications. So what are the principles of deprescribing? First of all is having that accurate medication list, and that's why in the hospital medication reconciliation is such an important issue, and obviously working with a pharmacist is so important. The next thing is clarifying the indications for use that the patient's medications have. And I liken this to one of those little games you played as a kid where you have two columns of words and you try to link up the things that have two similarities. So every medication should have an indication, and I think that indication should be reviewed as being, is this appropriate for this patient? As I mentioned, part of deprescribing is clarifying what medications people are actually taking. It's pretty easy to deprescribe something if the patient hasn't taken it for 4 months, if they are not having any negative consequences of their non-adherence. Identifying adverse drug reactions, we've talked about some of the things that you might see, but this is this is easier said than done. Once again, including the concept of drugs causing symptoms is probably your first step here. and the reactions may range from the classic ones found in the CPS to very non-specific atypical ones that you might expect with any illness in a frail older person. So once you've done these preliminary steps, your next thing is to, put an X through some of the medications that you're targeting for cessation, and obviously you can't just X out the prescription. You have to figure out a plan for deprescribing. And that often involves prioritizing which is the most important medications. That would be clearly the ones with the biggest short-term or even long-term consequences. So a medication that's contributing to falls or overt recent onset of confusion in the form of delirium would clearly be a priority. The timing is very important, however, as if somebody's having falls that seem to have been accentuated by an SSRI, it's ill-advised to stop that abruptly. So you need to figure out not only the planning of the timing of different medications you may wish to stop, but how quickly can the ones that I'm targeting be stopped. Simplicity is obviously important, and trying to write down your plans and provide and involve caregivers as well as the frail older person in the process is really important. And most importantly, monitoring once you've set the ball in motion for the deprescribing is trying to clarify what are the monitoring needs for that patient. And that may be clinical, it may be advising patients on side effects, it may involve blood work, but I think as part of the deprescribing process, planning and documenting your monitoring strategy is really important. And as I alluded to, clearly partnerships are crucial here. So what about peer pressure? Sounds like a funny thing to say when you're talking about physicians, because we're all absolutely incorruptible. However, I think that we all know the studies, we all know what our patients are supposed to be on, and it's an interesting question as to what our impressions when we send somebody to a specialist and the person isn't on whatever drug that particular specialist is supposed to be an expert in. So I mentioned the HOPE study, which looked at spironolactone, thinking of our previous, so HOPE study was looking at ACE inhibitors in heart failure, the RAIL study was looking at spironolactone, and God knows statins are a controversial enough field. So think of that. You should be willing to justify your decisions to have people off things, and be aware of the fact that sometimes we are concerned with what people will think when they see our medication lists. So I want to close off before we go back to some of the cases that I put up earlier as a few final words of wisdom. I think medication can cause illness, and in frail older people, illness equals decline in function. When in doubt, consider stopping medications, particularly ones that are not to treat immediate symptoms. Be methodical in stopping, one at a time when possible. And a question that comes from the literature on end-of-life care in non-malignant diseases is, would you be surprised if this patient was dead in 6 months? And I think, clearly physicians are not good at prognosticating, but this is a not irrelevant question to at least keep in your mind when looking at medication lists. I call the very low doses of medications that are probably not doing very much for the patient as a defecate or get off the pot dose. And by this I mean 1.25 or 2.5 milligrams of ramipril has very little evidence in the literature for benefit, so either increase it if the patient needs it increased, or that might be a good medication to deprescribe. Another type of thing is very, very low starting dose of an SSRI. Is it the patient's mood better? If not, was the SSRI the cause, or did you do something else? And if the medication's not better, start low and go slow, but for God's sake, go. Any drug that has anti in front, such as anticholinergics, are always good drugs to target. And another quote I like to use is, "The road to hell is paved with forgotten therapeutic trials," meaning that many people's medication lists will have drugs that were started with a specific therapeutic goal, and the lack of follow-up to clarify whether that goal was reached resulted in the medication being kept on indefinitely. So if you start something and you're not sure if it's going to be helpful, set a time frame, set your criteria for review, and get rid of the damn stuff if it's appropriate, as in the patient's not helped by it. So obviously we don't have scope for questions, but I'm going to move us back up to the cases just to look at the types of approaches that you might end up taking. So this gentleman here, the man with the end-stage heart failure, he's made his goals of care clear. And I think one thing you want to avoid is routinely stopping medications if there's a potential benefit from them from a symptom point of view in this sort of circumstance. Spironolactone helps to improve mortality, does not have an impact on symptoms, great drug to get rid of. Ramipril may have benefits in symptom control as well as longevity, but if he's having trouble with renal function, this may be expendable. Digoxin is worth considering tapering off, particularly if he's having side effects from it as he's in sinus rhythm, but it does have some potential symptomatic benefits, so you would clearly want to monitor here to ensure that the symptoms are not worse with the withdrawal of the digoxin. Lasix, do not stop the Lasix if he's short of breath. You might want to change the timing of it to make it more tolerable. Divide it up, it might be more effective. But I think here the Lasix is actually something that I've seen house staff in hospitals stop because they think it's not really helping, but it's going to be very relevant for dyspnea. What medication may be missing? If he's very distressed due to dyspnea, a low dose of a phenothiazine like Nozanan or even the use of an opiate might be something to actually add here as opposed to just worrying about what to stop. I don't know about this one because I cannot find the evidence as to when the benefit from being on anticoagulation starts to be outweighed by the risks. So here, most important concept is having the discussion with the patient and ensuring that they are in agreement with the risks and the benefit equation as you outline it. So here, the best example or the best approach is discuss it with the patient and describe the paucity of evidence for people in their 90s, and often they will tell you what they want. I've had a lady in her late 90s that was very fearful of a stroke, was willing to live with the risk, and likewise someone recently in their 80s that had enough concerns appropriately about the risk of bleeding to say forget it. Why would I not start this 88-year-old? I would consider it in anyone being admitted to a long-term care, but this particular person has a prognosis in the short number of months to short number of years, and the benefit from a bisphosphonate will not likely to be accrued for 12 to 18 months, and even then it will be minimal at that lower point. So one rationale here could be the fact that the patient prognosis would not be likely to allow them time to get benefit from that particular medication. Here, I think I would be able to cite the evidence that this gentleman, the Crestor would be for primary prevention, and therefore there would be a greater risk of adverse reactions with very minimal benefit from his perspective. So aspects of communication, aspects of knowledge of the literature, aspects of common sense are very relevant in addressing patient concerns. And although many patients say, you're the doctor, go ahead with it, if you never engage them, you'll never hear their input. So I could talk about this for many hours more, but it might be better to do it at a small group session at a Canadian Geriatric Society meeting somewhere down the road. I think hopefully you'll apply this knowledge practically, because the reality is that managing medications is one of the most important things we do for our older patients, whether we're in general surgery versus being a geriatrician. If you have questions, I'm sure I can find a way of answering them online. And thank you very much for the opportunity to do this once again. Best wishes.